Good morning. My name is William Bill Martin. I'm a senior fellow at Rice University's Baker Institute for Public Policy, where I direct the Drug Policy Program and the Religion and Public Policy Program, both of which have substantial interest in the topics of today's webinar. I welcome you to this program. Thank you for joining us and promise you an informative and stimulating hour. Today, the Baker Institute has the privilege of partnering with the Hackett Center for Mental Health, the first regional center of the Meadows Mental Health Policy Institute, to discuss mental health in the context of, or perhaps we can begin to hope, in the aftermath of COVID-19. The goal of today's event is to shed light on decisions made during the most recent Texas state legislative session and the impacts of these policy decisions on mental health and substance abuse services here in Houston and the Gulf Coast region. But before we get to that, let me set the stage. Even prior to the COVID-19 pandemic, studies indicated that 1 in 5 Americans was living with a mental health disorder. Deaths by suicide had been steadily rising for over 2 decades, and by 2019, suicide had become the 4th leading cause of life years lost after heart disease, lung cancer, and automobile accidents. Inequity and the burden of racism, which often lead Black, Indigenous, and other people of color to receive less culturally responsive care and face additional barriers to access, had led marginalized communities to experience higher risk of poor health outcomes for a range of health conditions, including mental health, illness, and addiction. The pandemic has substantially worsened this pre-existing epidemic. In the past years, rates of death from overdose jumped by 33%. Symptoms of depression have increased 4-fold. The number of people seriously considering suicide doubled, and emergency department visits for mental health needs by children have increased by 1/3. No surprise, the disproportionate impact of COVID-19 on communities of color has worsened underlying inequities. We also know that the pandemic has caused significant amounts of trauma and grief, especially in our region, where we have cumulative impact from loss from COVID-19, hurricanes and tropical storms, and even devastating winter weather. Yet, there is hope. One of the primary lessons the COVID-19 pandemic has taught is that a nation can rapidly scale up and deliver early detection, treatment, and prevention if we pair the will to act with the necessary resources. Today, we're going to look at how the Texas State Legislature has responded to the challenge of mental health in the context of COVID-19, and what we can expect that to mean for Houston and the Gulf Coast region. So on that note, let me introduce our moderator, Dr. Larry Blau, Executive Director, I'm sure he has a nice office as well, Executive Director of the Hackett Center for Mental Health. Dr. Blau.
Thank you, Dr. Martin, for that warm introduction and for those words. We're delighted to be co-hosting this event with the Baker Institute. For those who may not be familiar with the Hackett Center, we were established in 2018 through a transformational gift from Maureen and Jim Hackett. We have a focus on putting policy into practice, and we engage and support the development and dissemination of best practices in the mental health area, research, and implementation among healthcare leaders, organizations, and systems here in the greater Houston and Gulf Coast region and beyond. Now, we have a lot to get to today, so we're going to go ahead and get started. First, we are joined by Nelson Jaron, the Senior Vice President of Government Affairs for the Meadows Institute. He's going to provide a summary of behavioral health related actions of the 87th Texas legislative session, which ended just mere days ago. That will be followed by a panel discussion where we're going to delve deeper into the potential implications of those decisions for Houston and our greater Gulf Coast region. So with that, we want to thank you all for joining us, and I'm now going to turn it over to Nelson Jaron.
Thanks, Gary. Good morning, everyone. I'm going to share my screen, my slides here. Give me one second. Sorry for the delay there. Had another window in front of me there. So good morning, everybody. Nelson, Jaron, happy to be with you here this morning. As Gary mentioned, the legislature just wrapped up on Monday. So we're in the veto period now, and we're going to give you an update. This is not by any means everything that was accomplished this legislative session. I'm just going to hit a few highlights due to the timeline here, and then we'll discuss more during the moderated session, some of these items and a few more details. But we're also working on a legislative wrap-up that we'll send out to attendees afterwards that gives a more detailed view on the items that I'm not able to get into today. So just going to hit a few high points. For the 87th legislative session, it was a session like no other due to the first pandemic that we've had since the Spanish flu in the early 1900s. I haven't lived through anything like this, but it was a different beast at the Capitol for sure. The legislature started off slow, of course, because January and February were just getting through the winter holidays. There was a lot of restricted access. Vaccines weren't rolling out particularly quickly just at that time. So it really evolved over the last few months and got somewhat back to normal by the end of legislative session, but by no means didn't start with that. A couple high points from legislative session, just to give you some background. Senate Bill 1, which is our budget that we pass for the next biennium, the 2022-2023 biennium. The state writes a budget 2 years at a time. That's nearly $250 billion is what they wrapped up this legislative session for the next 2 years. I'll reference SB 1 or Senate Bill 1 a few times during my presentation, and just know that that's things that were appropriated or funded through the budget. The 87th Texas Legislature overall, they appropriated over $8.4 billion to behavioral health. That's across 25 different state agencies. So the legislature, as of a few sessions ago, they now track the amount of funding that's spent on behavioral health, so we can look at an apples to apples comparison each session. That's also to make sure that all of those 25 different state agencies that are receiving state taxpayer dollars are working together and making sure that they're coordinating and they're not duplicating efforts. But that's roughly a $350 to $360 million increase over the 86th legislative session from 2019. So not very many industries or people can say that about this legislative session, because that budget at $250 billion is about even over what they passed in the 2019. So it's about level funding, but behavioral health did see, I would say, a sizable increase for this legislative session. The other key thing, because of COVID, there was less opportunities to work on legislation, file legislation. That didn't affect the members of the House and Senate from filing bills. They still filed nearly 7,000 bills this legislative session. But because of that slow start at the beginning of session and some tension between the House and Senate at the end of the legislative session, note that only about 15.5% or a little over 1,000 of those 7,000 bills passed this session. That compares to 19.5% back in the 86th session in 2019. So generally you say 1 out of 5 bills make it through the finish line. It was even fewer this time. So a lot of people were disappointed that their priorities did not make it across the finish line this legislative session. So let's talk about a few things that did make it over the finish line this session. One key thing, that was a defined priority for us, just reacting to COVID. Starting in April of last year, we published a series of white papers to make sure that the mental health impacts of COVID were front and center. Dr. Martin mentioned the increases in child use of the emergency department for suicide and crisis, as well as the increased numbers 4 times over baseline for anxiety and depression. So we knew that a big effect coming into this legislative session is we needed to make sure that the Texas Child Mental Health Care Consortium from last legislative session was adequately funded and was continuing to scale up their initiatives. Briefly, the consortium was passed through Senate Bill 11 in the 2019 session, and it provides funding to all 12 of our medical schools across the state to work on 5 key initiatives around children's mental health. I'm going to hit on 2 of those briefly. One is the Child Psychiatry Access Network. This is critical because it's 12 hubs that are all cover different regions of our state, and any pediatrician or primary care provider in those regions can now call a 188 number, toll-free number, and they'll be automatically routed based on where they're calling from to the hub in their region. So any pediatrician or primary care doc has that resource right now, completely funded by the state, free of charge, to call and be routed to the hub in their region for support with addressing the mental health needs of their patients in their primary care practices. So we just celebrated the 1-year launch of that on May 20th. Over the last year, more than 5,000 pediatricians and primary care providers have enrolled statewide, and it served nearly 2,000 patients. So we wanted to make sure that that's kept going. That's especially critical as we see more kids with mild and moderate conditions due to COVID appearing in primary care and pediatric practices. And the second thing I wanted to hit on real quick, other initiative of the 5, is the Texas Child Health Access through telemedicine. Just like the CPAN works through 12 hubs, those medical school hubs also have funding to provide telehealth services to school districts, K through 12 students in their regions. This last year, due to COVID, they were ramping up. There was a number of medical schools that had provided these supports before. They were able to expand to some new districts, but of course, not everybody was in-person school in this last fall semester. So they had to do some modifications. Some people like UT Health in Houston started actually working with families in their homes until they were able to get back in school. But this has been steadily expanding over the past year, despite COVID. And in the fall semester, they expect the TCHAT program to reach more than 2 million Texas students. So it's seeing awesome growth, reception from our ISDs across the state. In the Hackett Center region, the key thing to note is that you have hubs at UT Health Houston, UTMB in Galveston, and Baylor College of Medicine. So all 3 of those are receiving funding through the consortium for all 5 initiatives, but particularly here talking about the Child Psychiatry Access Network and the TCHAT initiative. So SB1, the Senate budget, provided a $19.5 million increase for the consortium. That provides them with the increased funding they need to maintain services over the next 2 years. And in the Gulf Coast region, between those 3 medical schools that I just referenced, that translates to them receiving about $35 million from the state to fund their 5 initiatives. So a big win for our medical schools and our kids. I'll be brief on this next one here. This is collaborative care. This was another priority of ours because of the impacts of COVID. Again, talking about the consortium, the key thing was CPAN, children coming into pediatric and primary care practices. The same thing with adults coming into their regular primary care practice. Nearly 75% of mental health cases, when they present in a primary care practice. So we need to enable those primary care practices to provide the treatment there. We can't expect to refer everyone to a specialist and do what we don't do for any other type of health condition and just say, well, we don't treat that in primary care, but here's a referral. We don't do that for anything else. We're trying to provide integrated care in our primary care practices for mental health, treat our mental health and physical health together. Andy's going to talk about this in the question and answer session, as I just mentioned. But on a high level, this is a evidence-based practice to treat, to integrate a behavioral health care coordinator and a psychiatric consultant working together with your primary care provider to address mental health issues and substance use issues right in your primary care practice. The key thing with this is that it's a cost saver because you're treating physical and mental health conditions together. So there's numerous articles out there that show that it's a true cost saver. It's also a lifesaver. We know if we expand universal access to this and for major depression, that we can significantly reduce the number of suicide deaths that Dr. Martin talked about, the uptick in suicide deaths. We can also help counteract opioid or overdose deaths through this as well. But the key win here was Senate Bill 672 by Dr. Don Buckingham. That's awaiting the governor's signature now, but it authorized Medicaid reimbursement for collaborative care. So it can already be reimbursed through Medicare and through commercial health plans. This was the missing leg of the stool, was having that Medicaid billing. So Andy will talk more about implementation in the Gulf Coast region shortly on that. Other big thing for the Houston region, state hospital system redesign. The state hospital system redesign process began back in 2017. It was intended as a 3 biennium process. So the legislature was committed to appropriating dollars to it for 2017, 2019, and 2021. Back in the 2017 session, there was $300 million appropriated, and UT Health received 125 million of those dollars. And that was for the Harris County Psychiatric Center that's right off 59 near the Houston Zoo in Houston. That was built in the 1980s. It's operated by UT Health, and that was for them to build a brand new HCPC2, or Harris County Psychiatric Center 2, right next door to the original Harris County Psychiatric Center. So that started undergoing construction. It's been building over the last few years, and it's going to be ready this fall for the keys to be turned over to UT Health, and was recently named the John S. Dunn Behavioral Sciences Center. So instead of calling it HCPC2, they're going to honor Mr. Dunn. I believe he just recently gave an endowment to the Behavioral Sciences Center, and it's going to bear his name. So as far as what the Gulf Coast needed this legislative session, they needed operations dollars in order to open the building and fund the beds that are in there. You already had the construction dollars from phase 1, so the big phase 3 item to check was getting the funding for that. Ultimately, when this facility opens in February, it's 11 units, totaling 264 beds. And the state, through the Senate Bill 1, the state budget is providing a little over $40 million to phase in those beds beginning in February. They're going to have a opening event on February 2nd, 2022 at 2 p.m. They coordinated that, UT Health did. And it's going to have 168 beds the state is going to be using for their use. And then UT Health will be able to contract with providers and use private pay and others to fill the rest of those units. So it's going to be a state-local partnership. And what that's going to do is currently the designated state hospital for Harris County is Russ State Hospital, which is about 3 hours north. Well, now we're going to have a brand new state-of-the-art state hospital facility that's operated by UT Health Medical School right there. So it's a game changer, I think, not only for Harris County, but the surrounding counties, and it'll provide quality care closer to where people live, work, and have their family and supports. Another key win related to Harris County was MultiSystemic Therapy. Just at a high level, just know that MultiSystemic Therapy is a well-established and a rigorously tested evidence-based program for at-risk youth with intensive needs. So targeting youth roughly ages to 12 to 17. These are people that have often committed violent offenses, or they have serious mental health and substance use concerns. They can be people that are out of risk of out-of-home placement or becoming into our child welfare system. So people that have experienced abuse and neglect. But this is a proven evidence-based treatment that you work with the child and the family for roughly 3 to 6 months, and it can completely turn their lives around. The key thing in Texas is that in the entire state, we only have 3 MST programs. We have 1 in Harris County, we have 1 in Nueces County, and we have 1 in El Paso County. So Dallas, Austin, where I'm at, San Antonio, no other big cities other than Harris County and Houston have MST available to them. Currently, Harris County has 4 MST teams. They're able to serve roughly 20 kids at a time, 50 over a year. So maximum capacity, roughly 200 for Harris County. There's a lot more need than that. The other key thing is right now, these MST programs, they have to be in the juvenile justice program in order to get access to them. So we don't want to wait until kids get in the child welfare system or juvenile justice system in order to get them access to the treatment that we know that works and that we know they need. And so the state budget, Senator Huffman out of Houston championed this. She provided $1 million in there to fund a new front-end MST team in Harris County that's going to be operated out of the Harris Center. But what that means is that you don't have to go to juvenile probation to get on this MST team. This is going to be targeted to kids, again, youth between ages 12 and 17, with the goal of keeping them out of juvenile justice and the goal of keeping them out of our child welfare system. So that's why it's a front-end MST team. It's all on Harris County now. You guys are going to have 5 MST programs down there. But I think that this provides a good opportunity for Harris County to demonstrate the effectiveness on this program and how it can be a statewide model for the legislature when they come back in 2021 to keep kids out of the juvenile justice and child welfare settings. And then finally, I briefly want to hit on the federal COVID relief funding. So when we talk about what the state legislature did, we talk about Senate Bill 1, the state budget. That doesn't that doesn't really include a lot of the federal relief funding. There is some included in there from past bills. There have been 6 relief bills passed since last March when we started this pandemic 14 months ago. And they were able to use some of those initial dollars to help us balance the budget this time. But since then, there's been 2 big bills. President Trump, his last act was really to sign a big COVID relief bill on December 27th, which is known as CARISA. And then President Biden, of course, one of his first acts as president was to shepherd through a nearly $2 trillion plan known as the American Rescue Plan Act. That's also referred to as ARPA down at the Capitol and kind of in this acronym soup of federal and state lingo. So the key thing to know about ARPA is that one, it's a massive bill, $2 trillion. It's huge and has a lot of different funding streams that we're working and tracking to make sure that communities are aware of and they're using, that they can be used towards mental health resources because we know the effects of COVID on our mental health. So SAMHSA, which is the federal entity that oversees substance abuse and mental health services administration or mental health services, they receive $3.5 billion. The CARISA Act that I mentioned that President Trump signed, they received over $4 billion through that. So nearly $8 billion is going to SAMHSA. Those dollars are all going out to our mental health and our substance use providers from the state. So the dollars are flowing down from the federal government to the state agency, the Health and Human Services Commission, and then out to our providers across the state. But there's 2 other funding streams to know about that are coming directly to our communities. One of those is the funding known as ESSER 3. There's been 3 rounds of elementary and secondary school funding. This latest round is by far the biggest, ESSER 3. The state of Texas is receiving a little over $12 billion total, but a little over $11 billion of those dollars, roughly 90%, are going straight out to our school districts. And the reason for those is that they're supposed to help address the effect of the COVID pandemic on our schools, help with COVID-related learning loss, and they can also help deal with the mental health impacts of the students in our K through 12 systems throughout the state. So it's a massive amount of money. Just to give you an idea of what that looks like on the ground, Houston ISD is receiving $804 million from this. So nearly $1 billion is coming, and they have a few years to use it. So these are one-time funds that they're coming. They're already there. They have the first distribution. There's going to be a second distribution for the rest of the dollars, but it's a massive amount of dollars. So we're working with school districts all across the state to help make sure the dollars are spent most effectively and appropriately to help address the needs of students. The other big thing to note is the state of Texas also is receiving direct dollars. This only happened one time before in the CARES Act. Early last year, there was dollars that went to state and local government. Again, this bill is a lot bigger. So the state of Texas is going to receive nearly $16 billion. The legislature hasn't done anything with these dollars because they're going to have a special session later this year for redistricting and a few other things that blew up at the end of session. And Governor Abbott is committed to putting these resources on the call or the items that the legislature can consider during the special session. So that should be in September or October of this year. The legislature will make decisions about how to spend this $15.8 billion. But again, just like the school funds, they're one-time funds that they have a few years to spend them, and they're targeted towards coronavirus items. So responding to the coronavirus crisis. And then finally, Texas cities and counties, just like the state of Texas is receiving a direct funding stream, Texas cities and counties are also receiving a direct funding stream from the Department of Treasury. So the cities in Texas, these are cities over roughly 50,000 in population. They're going to receive $3.4 billion in direct dollars straight from the Department of Treasury at the federal level, while our counties, all 254 counties across the state, are going to receive $5.7 billion in direct payments. Again, these are massive dollars. You just think about our budget for our entire state that I start off with, $248 billion. And these, between these 3 funding streams here, is $35 billion. So roughly 15% of our biennial budget coming in payments to our state for COVID. And finally, on the cities and counties, just to give you an idea, Harris County is receiving $916 million, nearly $1 billion coming through their direct appropriation. The city of Houston is receiving a little over $600 million. So again, just like we're working with schools across the state, we're also working with counties and cities across the state, local governments, to help them best spend and recognize the mental health needs, along with other challenges that our governments are working on as we recover from the COVID-19 pandemic. And with that, that was a lot of information in 7 slides. Happy to answer questions. We can follow up with questions in the chat or answer offline. I know they're going to have a moderated discussion next to get into this a little bit more in detail, and also happy to be a resource for you once we get out that legislative wrap up that will have these items as well as many others that the legislature accomplished this legislative session. We're here as a resource for you and look forward to visiting with you. And thank you for having us today. Thank you so much.
That was awesome. Thank you, Nelson, for an amazing and informative overview. There really is a lot to unpack there, and that's going to be the task of this panel, which I am pleased to introduce. So joining me to discuss what all that impressive activity on the legislative front means for Houston and the Gulf Coast area are Kelly Hackett, who is the Managing Director of Tectonic Advisors Family Office Division and Vice President of the Hackett Family Foundation. Hi, Kelly. Dr. Andy Keller, President and CEO, and the Linda Perryman Evans Presidential Chair of the Meadows Mental Health Policy Institute. Hey, Andy. And Dr. Keonta Moore, who is with Rice, a Huffington Fellow in Child Health Policy at the Baker Institute. I welcome all of you to our panel today. And I would encourage anyone that has questions, please use the chat box. If we don't get to them during the panel, we would be happy to follow up with you after the fact with responses, and just to know that we're interested in providing as much education and resources as we possibly can. Let me start by saying that, one of the single largest legislative successes over the past 3 sessions has actually been the creation of the Texas Child Mental Health Consortium. I'm going to start with Dr. Keller, who's had an instrumental role in the development of that particular body. Dr. Keller, can you tell us what this consortium means for Houston and the Gulf Coast area?
Yeah, Gary, I'm happy to. Did you call me Dr. Keller?
I did, and I was trying to be formal, but yeah.
All right, thank you, Dr. Blau. Yes. So it's exciting. I mean, if we think about this, mental illnesses are pediatric illnesses. 75% of mental illnesses are happening in your life by the time the brain stops developing in your mid-20s, 50% by the time you're 14. Unfortunately, today we wait 8 to 10 years before we provide people with care after their symptoms emerge. And this is something we've done for other medical conditions. I mean, one thing I struggle with is heart disease in my family. My grandfather was diagnosed with his heart disease after they resuscitated him from his heart attack. I mean, that was the moment that they knew he had heart disease. And that's when they sent him home after he got out of his coma to be on a low cholesterol diet. Whereas me, they tracked me down way early in my 30s. They started haranguing me about my cholesterol and trying to get me to be more healthy, and they've been moderately successful at that. And that's basically what we're trying to do now through the consortium, is to make these care available to children through their primary care practices, because that's where we find things. If we wait until parents notice or until the school notices or the child starts complaining about the symptoms, we've waited too long. I mean, it's like cancer, other things. If we wait until life is being disrupted and problems are emerging, then too often we're going to see children come to an emergency room. And we also don't have enough providers to give everyone, line everybody up with a therapist. We have to really organize how we approach them in collaborative care, and the consortium together really provide a powerful combination of bringing the medical resources of our medical schools, where we have more child psychiatry. I mean, at UT Health Houston and Baylor, we have tremendous numbers of excellent psychiatrists, residents, others. And it's a fantastic example, Gary, to me, of the Hackett Center's motto of putting policy into practice. I mean, basically, these were happening in small scale in Houston and other places. We were able to learn more about that before the last legislative session. The Hackett Center's efforts to ramp up trauma based responses in partnership with schools informed that as well. And so going to the legislature basically said, let's scale that up. And so now we were able to come back and, as Nelson explained, reaching millions of children by expanding telehealth in partnership with the 2 lead medical schools in the Houston area, as well as the other 10 medical schools across the state that are in partnership with them. So it's fantastic. And millions of children are going to be better prepared, and their parents and their families, to have these supports, which also means a lot fewer of them will get put on medication because we won't wait until things get bad. There's just so many ways in which this is a fantastic thing, and it really exemplifies that your model, Gary, of putting policy into practice, making the effective stuff happen there at the Hackett Center.
Thank you, Andy. That's awesome. And just to add to that, the TCHAP program and the connection with schools and the use of telehealth is actually a national model. And we're excited that Texas is leading the way. And certainly here in Greater Houston, that we're doing, such a great job. I think Nelson alluded to how they had to pivot during COVID, because most of this from the school to getting consultation, and they started to be able to provide services actually through, when people are in their homes, and give folks a lot of credit. And having the fully funded approach is going to help us for many years to come. So that's really awesome. Let me turn my attention, Dr. Moore. I know that you're actually one of the evaluators of the Senate Bill 11 and all of this, which established the consortium. Can you tell us a little bit more about how you go about measuring the impact of a policy like this, and how the evaluation can actually inform both future legislation and also what the policy implications are?
I'd be happy to. So, first I want to say, because, for the audience may or may not realize this, but the fact that evaluation was built into the consortium is really incredible. So I am often called to evaluate things long after they've been implemented or decisions have been made about them. And as an evaluator, it's actually quite difficult, because the data that's available, long after programs have been implemented, may or may not be helpful in determining, the outcomes that they, hope to do. I find that, and, if you're in the nonprofit space, including the Hackett Center, you may, appreciate this, that often, you have a mission, you have a vision, you have passion, very similar to the clinicians who are part of CPAN, and, they just want to serve. And they have this long-term goal of improving mental health outcomes, or long-term goal of increasing access to care. But all the steps that it takes to actually reach those outcomes, they don't have a partnership with someone who's able to give them this rapid cycle feedback. So the real value of having an evaluation team on this is that we're able to provide this rapid cycle evaluation, to where, as they're implementing the program, we can look at what are the processes, what are the capacities, are all, we talked about equity at the start. Dr. Martin, opened us up really talking about these disparities. And so if our goal is to increase access, particularly to those communities who are most at need, then we need evaluators that, as people are doing the hard work and doing the day-to-day of seeing patients and tapping into the network, that there's guidance on, hey, we realize that in looking at your numbers, you might not necessarily be reaching the population that you would hope to, and then providing recommendations on strategies. And so when you look at outcomes, it's really important that people understand that, a lot of times evaluators are seen as the bad guys, right? We're the inspectors. We come in and we either give you your grade of A or we give you your grade of F. But we intentionally, my partners and I, designed this to follow Harvard's framework around program implementation, which really is this rapid cycle. And the outcomes that we're looking at are continual and progressive, meaning that initially we're looking at outcomes that are related to implementation, to make sure that the program's being implemented in a way that is going to maximize the chances of reaching the intended outcomes. And then we have short-term outcomes in between. How many patients are you able to receive? How many can we project? You were able to get them early enough before they needed, advanced treatment. And then longer term. So what is the cost and what is the return on investment? So I just want to say that this was a really smart thing to do, not just in the design of leveraging primary care providers who are on the front lines and seeing the patients and then providing them the support. When I was in medicine, we called it curbside consult. So if you were a physician and you had a patient and you weren't exactly sure how to manage the patient, but you weren't certain that they needed a formal referral, you would do a curbside. You would pick up the phone and call your colleague and say, hey, I have this patient, give me some guidance. And so I was so impressed that they've taken, a practice that's very common amongst physicians and really formalized it and be able to brought it to scale across the state. And so I'm excited to be part of the evaluation team, and our results are yet to come.
Awesome. Thank you. And it's very complicated, when you take these big issues and then try to distill it down into an evaluation to get this. And it's so important. And when I think the importance of putting money into doing this helps to make sure that we can do quality improvement activities going forward and really focus on what is working. And if something's not working, let's do course corrections now. I will say that in a response, we had a question in our Q&A. Vic, you had identified that yes, it's significant and shocking about how much mental illness has been occurring, and especially in our children and youth. And the question is, will there be an opportunity to obtain a video or audio of recording? And the answer is yes. We'll be sending that out. This is being recorded and will be on the Baker Institute YouTube channel. So we'll please feel free to share and generate conversation about the importance of how we all need to care for everyone's mental health. So thank you for that question. And please, if you have others in the chat box or the Q&A function, we'll be monitoring that. Let me turn to Ms. Hackett. Kelly.
Please call me Kelly, Gary.
You and your family have really been longtime supporters and advocates for mental health. One of the questions that folks ask is, why are you, shifting, some of your focus from programmatic into policy as opposed to like the direct care kind of thing?
Well, I think the best way to answer that is to give a little bit of insight into why my family is so interested in and dedicated to mental health and mental health philanthropy. And that really stems from lived experience. We, as the Hackett family, are a part of the 1 in 4 Americans who will experience a mental health condition this year. And that's been the case for our family for many years, multiple generations, in fact. As a result, we've had family and friends and colleagues and a lot of personal experiences that have shown us both the best and the worst sides of the healthcare system. And while we're really lucky and fortunate to be able to access care and afford treatment when and where we need it, that's not the case for so many Americans who are suffering in silence and who are not being given the access to care that they deserve. And our family has always wanted to do more to be a voice for the voiceless and to advocate on behalf of our fellow community members. So when we first started in the space, we did start, like many philanthropists do, by funding programs and services, particularly in our local communities. We started in our backyard, and that continues today to be a really fulfilling and important part of what we do through the Hackett Family Foundation. But after some time in the space, we felt like we needed to really assess where things were going. Is our values aligned with our giving? Is our giving aligned with the outcomes we're hoping for? And quite frankly, we found ourselves a little miffed and disappointed in the pace and overall scale of progress in the space, or the lack thereof. And we felt really strongly that more could be done. I think more importantly, we even felt that we had a role to be drivers of systemic change. And so we knew we wanted to level up our philanthropy, if you will, and started to think of the best ways to do that, and ultimately decided that was through policy investment. Because through policy, we can use our philanthropy, our voices, our volunteerism, our networks to leverage the resources of all stakeholders, including the government and the business community, to really create long-lasting, impactful change. And that's ultimately what we wanted to do. I think we heard earlier through Nelson's overview that's really paying off. We're seeing return on investment. Our investments in policy, whether they be through the Hackett Center or the Baker Institute, we're seeing those smaller investments be parlayed into millions of dollars that are going into widespread and sustainable change that will inevitably affect tens of thousands, if not hundreds of thousands of people. That's amazing. When you think about how our seed investment can be compounded and create a domino effect for the betterment of humankind, I mean, that is the core of philanthropy, right? Love of humankind. We are, without a doubt, attacking our mission head on. And as a family, we hope that that can serve as an example and maybe even an inspiration to other philanthropists to be a part of that sort of effort, to find themselves in a similar role where we can collaborate for the betterment of everyone.
Thank you very much, Kelly.
Sure.
I would add in the Q&A section that one of our attendees said to thank you for your personal openness about your family's struggles with mental health, because personalizing this is such a strong tool, as they say. And so I don't know if you respond.
No, I really appreciate that. I've grown up around comfort around these issues for so many generations, but it's funny because my mom always feels like she wants to tell everyone, oh, we're all in therapy. We're all medicated. The Hackett's are more than happy to talk about that. So I appreciate that comment and hope that people can recognize that mental health, doesn't discriminate. It affects us all.
That's great. Thank you for that. Moving along in our conversation, I'm going to turn back to Andy again. Andy, Nelson talked a lot about the legislation to implement collaborative care in Medicaid across Texas. To me, at least, this is a huge advance for healthcare and particularly for mental health care in our state. Can you describe, sort of from your perspective, what makes collaborative care so important, both here in Houston and across, Texas, and what kind of difference should we expect to see as a result of this legislation?
Yeah, absolutely. So collaborative care is not super fancy. It's very straightforward, which is why it works so well. So basically right now, primary care practitioners are bearing the brunt of mental health service delivery. Most psychiatric medications are written not by psychiatrists, but they're written by primary care docs, internists, family physicians, pediatricians, OBGYNs. And so that's where it's happening now. So we're not talking about shifting care to primary care. What we're talking about with collaborative care is embedding resources to help the primary care practitioners do better. So basically, in addition, so right now, like my primary care practice has a nurse, and he comes in and he takes my blood pressure. He does a bunch of things. So when the doctor comes in, they have the data ready. They can make decisions. And the nurse will talk to me about diet and other things that the doctor doesn't, need to take the time to do. What we do with collaborative care is we embed a behavioral care manager in the practice too, which you can either do virtually through telehealth. I mean, it works like we're doing now. Does it feel, Gary, like we're communing right now? We're on a first name basis. We've gone from formal to first name basis in just this short webinar. And so you can do that in the doctor's office. And so it basically puts the behavioral health person there. And they also have on call whenever they need them, a psychiatrist to collaborate, not just to do those sort of consults, but to actually prescribe and work with the primary care practitioner. The cool thing too is they work for the primary care doc. So I'm a psychologist. If a primary care doc, if Keonta as a primary care doc were to refer somebody to me, I would decide if I have time to see that person, is it a good fit for me? Are my expertise really ideal for that person? The behavioral health care manager does not decide. The doctor says, see this person, and they see the person. And that just makes things work more efficiently. And then they can also be a point to get somebody to a specialist like me or to Dr. Caplow at our Trauma and Grief Center. And so it's critical. So this is, the evidence is so clear. I think, Nelson went over that. And it's also really ties into what Kelly was talking about, because y'all, just because something works doesn't mean it happens in medicine. I mean, the typical time between when we know something works and when it's widely available is 30 years. So how do we accelerate that? And the kind of social venture capital that Kelly described that lets us put attention on something. And so there's pilots right now of collaborative care in both Houston Methodist and at Memorial Hermann. They've been going on with disrupt funds for years, but there hasn't been the bandwidth to look at them and to say, what would it take to scale that? What are the barriers? What is it that needs to change in the system around the like boring things like electronic health records being reprogrammed and new code written? There's a lot of mind-numbing details like that which because of the Hackett Center and because of the close look we're able to take, and we don't charge money, we go in there and we're able to figure things out. I mean, we charge money for some things, but like we have the bandwidth because of the Hackett Center to go in and where we're interested in a major policy issue, learn more and invest. We're able to put the evidence base together to get the legislature to approve this. And also to when there were questions about the cost, to come back with data and say, well, no, the cost actually will be spread out over years and there'll be return on that. So that sort of careful vetting, it's a beautiful use of philanthropy. A relatively small investment allows, well, hundreds of thousands of dollars is going to allow hundreds of millions of dollars eventually to flow through this system. And the reason Medicaid was so important to add is that's where most of our children in poverty receive their care. If Medicaid is not part of this, I mean, Blue Cross Blue Shield was my insurer and other commercial insurers cover this. But if we don't have it covered by Medicaid, not only will it not be available to children in poverty, but it won't be broadly available at all because you have to have all the payers really paying for this. Otherwise, it's not in the interest of the health system to implement it because they can't do one thing for some people and not for other people. So it's a huge win, really, for every child in Texas. And it's something that we'll be excited through the Hackett Center to be able to partner with health systems across the Gulf Coast to ramp up and be able to take advantage of this new funding.
That's awesome. And thank you, Andy, for saying that, because I think one of our goals at the Hackett Center is to be able to work closely with business providers and health systems to implement these kinds of best practices that have clearly been demonstrated through randomized controlled trials and the like, as you described, to be effective. So I think this is really great. I will encourage folks, if you're interested, please put a chat or Q&A in there and we'll take a look at it. And as you do, I'm going to turn to Dr. Moore again. And one of the things that I think has really been striking in information, not only here in Greater Houston, across the state and the country, is that COVID-19 has really revealed significant inequities in healthcare, including in mental health. Another area where we've seen historically and significantly disproportionalities is in the juvenile justice system. One of the big wins it has been that the legislature just put $1 million into Houston to expand what we've already have as far as MultiSystemic Therapy, MST, which is that service that Nelson described that has a very strong evidence base to assist young people that are not just in juvenile justice, that also may be at risk and keep them out of the system. Can you tell us a little bit more about why this is important and from your perspective, what further work needs to be done to address these kinds of significant disproportionalities?
Yeah, absolutely. So, as you mentioned, these disparities existed before COVID. So what COVID did was place a spotlight on these inequities and on these disparities. And for the purpose of clarity, I want to define equity. Equity is around an equal opportunity to be healthy, to have good mental health, to have access to services. It's really about equal opportunity. And so providing funds for MST to be more on the front line before kids enter a system that already has so much implicit bias, and there had to be so many systems that failed before that child entered into the juvenile justice system. This is significant for children because it provides access before they get to that point. And so that means that, the trauma and all the other things that even happen within the juvenile justice system gets to be avoided, and families can, get better, right? I mean, and that's ultimately, right, have better mental health outcomes before it reaches that point. I want to talk a little bit about, though, that we need to also be thinking about how do we avoid the point of even children needing MST? And so how do we invest in neighborhoods? How do we look at mental health and mental health investments as, looking upstream into early childhood development? When you think about, I looked at the list of things, add up, home placement and substance abuse and, criminality, all of those things, really start, the trajectory for those things really start very early on. And so we need additional strategies and additional things like Andy talked about, is that when we're looking at systems, I often say that children don't live in one system, They live in a variety of systems. So children are in homes and they're in neighborhoods and they're in schools. And, Nelson gave a really great overview of all the ways that our Texas Legislature and the Hackett Center has been involved in improving many of the systems that children encounter. And so I want to emphasize that we need to continue that. We need to continue the work of looking holistically at children, at creating access, equal opportunity for all children to be able to access services before they get to a point where things are so severe that they've already lost so much. What I mean by that, so I have a study in a major school district, and several of those schools were failing. When we looked at some of the root causes for why those children were failing, 25% of the high school students screened positive for depression. Those kids also had seen a murder or shooting in their neighborhood. So the relationship between access to services and mental health services really can't be separated by childhood experiences and things that children are engaging with, in the community. So your question, Gary, about sort of what's next or what do we need to keep doing? Well, we've made some huge gains. We need to keep doing that. We need to keep funding, and putting money in the consortium. We need to continue to support collaborative care. We need to keep doing evidence-based work, but there's still more work to be done. And it's not just at the legislature. So sometimes people think that, oh, we have to always do it in Austin, but there's really important work. And I think Kelly highlighted this here for philanthropists and other nonprofits to work together in coordination with the Hackett Center and the Baker Institute to develop strategies that we can implement on the ground. I mean, we have huge money coming from the federal government. We need to create systems and leverage those opportunities to do more locally.
That's awesome. I totally agree. And actually, in your Q&A function, Andy just responded to a question about how we share these resources in terms of MST. Andy, you want to expound on that real quickly?
Yeah, just quickly. I mean, there's resources there. We're happy to link you with other ones. But, the only way we were able to work with the legislature on this MST piece was, again, through a Hackett Center project where we worked with Harris County Juvenile Probation, which, by the way, does amazing services. The only problem is the entry criteria. You have to be arrested in order to get there, and then it's late and things are worse than they need to be, and then you got that on your record. So what this is about, and we planned this really with Juvenile Probation, they want to get it to people earlier too. So we were able to work with the Harris Center to figure out a way to actually expand the scope of what services there are now using Medicaid dollars. So the Harris Center was able to do that without this legislation, but now to get the legislation to do a team that you don't have to go through the Justice Center to get, you just have to have the need. And then the Harris Center will be able to help meet that need. So again, it's an example of what Kelly was saying earlier about how an investment where we can go research and figure out the building blocks, which often, I just can't say this enough, are boring. They're about financing. They're not clinical. They're not interesting. It's just getting the barriers out of the way. And then that's what the legislature needs to then move things forward. So it's very exciting to see how these small investments, these targeted looks behind the scenes allow us to find the policies that then we want to put into practice through the Hackett Center.
That's awesome. And thank you. And I'll say another question came through about how the audience can support the work at the Hackett Center. And, honestly, we're obviously we're looking for funding, ways in which that we can expand the work that we do. You can either reach out, contact us directly. We're happy to meet with you or to talk about ideas. We have many priorities and initiatives. Andy mentioned our work around trauma and grief, the trainings that we do, evidence-based practices, learning communities, the work that we're doing around our faith-based initiatives, and just a host of policy kinds of things. So feel free to contact us at any time, and we can talk about opportunities for that. Let me turn sort of another question or a final question to Kelly. It came up a couple of times here. Dr. Moore made a good comment about it, that reality here is that we're in the midst of not just the pandemic, but also a wave of sort of increased awareness about things like racial injustices or mental health issues. What are your thoughts, I guess, about how philanthropy can best address these increasing needs, particularly in young people, which I know we're also concerned about?
Yeah, I mean, there's absolutely no doubt that the last almost 24 months now has been devastating in so many ways. And it's part of why it's so great to be able to come together today and celebrate major wins like we've discussed with respect to federal and state funding. But I think it's also a reminder to all of us as to why we do what we do. And that's because we have a system that needs help and we all want to be a part of the solution. I'm excited as a philanthropist to have a seat at the table, to be considered a critical partner to other stakeholders, and to be able to fill gaps, which will always exist despite all of the funding that everyone's efforts has been able to pull in. Philanthropists will always be needed. There will always be resources that are required that are not being provided by other stakeholders. And it's up to us to educate ourselves as to what barriers exist. Like Andy Keller said, they might not be the sexiest or the most exciting things, but perfect areas where philanthropists can use resources they have outside of even just funding. Now, don't get me wrong, funding is critical, the most critical part of this, but to expand on what philanthropy really means and what resources I'm really talking about, philanthropists can offer all sorts of different resources. I think the most important asset that any philanthropist has is their passion for a cause. And if you take that passion and you use it to fuel your continuing education about the space in which you're operating, make sure you know who the conveners are, who the collaborators are, who the players are. Get your arms around legislation, get your arms around evidence-based programs, things of that nature. You can use that to empower your voice as a philanthropist and use that voice to get in front of decision makers and make sure that they're keeping mental health at the forefront of what they do all the time. Get in front of the entities and organizations that are receiving funding and make sure they're educated and informed, that they know the value and impact that evidence-based programs have, that youth and family programs have, sustainability programs. Those are the sorts of things that philanthropists can really do to help move the ball forward. Because what we want at the end of the day is not to try to return to where we were pre-pandemic, but it's to be light years ahead of that in terms of what we're doing for everyone's mental wellness. And I think the only way to do that is for all stakeholders to come to the table with every resource they have to really be a part of the solution.
That's wonderful, Kelly. And I think many of us would describe that as creating a system of care, where we're all working together. We're coming to the end of our time. Let me give folks just like one last, 20-second soundbite. What is it that, you want to say? I'll start. Kianta, anything that you want to add in 20 seconds?
I wanted to address a question about upstream factors. So upstream factors has gained some, prominence and recognition, but, to Andy's point, it's not as sexy, right? As saying like, we have this, amazing new treatment that we're going to come in and solve the problem. And often as an evaluator, it's difficult to measure the impact of some of those upstream investments. So I do want to say that upstream is important because the cheapest or most cost-effective or most, impact that you can have really is avoiding the problem to begin with. But if we can't avoid the problem, then a lot of the great work and interventions are really important, right? In order to address it and get people equal opportunities to be healthy.
Awesome. Andy.
Well, that's so well said, Kianta. And, and it's part of why collaborative care works, is we find things sooner. And there's a great point that was also made in the Q&A about stigma. Another reason why collaborative care works is you go to the regular doctor. And that also, by the way, is good because like people who are having mental health concerns also often have bodies attached to their heads that are affected by their brains. So being able to have all that dealt with in the same place is just good. And it does reduce stigma. It helps people just accept these are medical conditions. And so what we're seeing play out, for example, in the French Open with, being able to say, these are health conditions. So I'm going to decline to do an interview. That's what we need folks to be able to do. And I just need to take a moment too, Gary, to thank, in addition to, obviously the Hackett Center for sponsoring this and Rice University, the Episcopal Health Foundation has been a fantastic supporter of our policy work for years. And the work that Nelson does in the Capitol is directly supported by that, with a focus on the priorities of this region, including how do we use Medicaid, not as a political soundbite in our state like too many of our leaders do, but really as a tool to help more people in poverty get things they need sooner and more effectively. So really appreciate the support of the Episcopal Health Foundation. Wouldn't be able to do that work without them.
Great, thank you. Kelly, final word, 10 seconds.
Sure. I would just say collaborate, collaborate, collaborate. There's not enough of it in the space, and whatever we can do to collaborate brings transparency, which brings better strategic impact in the end. And it's the way that we're going to help the most people.
Awesome. Partnerships is key. Absolutely. Well, let me say, I put my email in the chat box if any folks wanted to follow up. If I know there's maybe a couple questions that we couldn't get to in this short time, but if you want to reach out in terms of what we do at the Hackett Center, ways to be supportive, or certainly, any further questions, please do not hesitate to email me. I want to thank our panel. I want to thank the Baker Institute for Public Policy and all of you for joining us at today's event. Again, I would encourage folks to visit the websites at the Baker Institute Center for Health and Biosciences, as well as the Hackett Center for Mental Health. We're at thehackettcenter.org. And you'll also see, again, my email. So please feel free to reach out. We thank all of you so much. Dr. Martin, appreciate your support and working with us on this as well. And you all, lots of good luck, and let's go out there and care for everyone's mental health. Thank you all.